And here to discuss ending rheumatic heart disease for the next generation is Pat Turner and Professor Jonathan Carapetis. They're the co-chairs of the End RHD Alliance. They're going to present a preview of the recommendations of the soon-to-be-launched Endgame Strategy, which will outline a comprehensive, community-driven plan to eliminate rheumatic heart disease in Australia by 2031. Importantly, they're also accompanied by Raychelle and Noeletta McKenzie, who will share their personal experiences of RHD and their work to empower communities as part of RHDAustralia's Champions for Change program. Thanks, Pat.
Good afternoon, everybody, and thank you very much. Very pleased to hear about the increased funding for our sector. First time I can remember in a long, long time. So on my figures, $90 million invested directly in our RHOs, plus indexation, which will be about 31 million, 100 and what? 20 odd million, extra money for the first time in a long, long time. And that's going directly to you, to your services. So, a special thank you to Minister Hunt for his commitment to closing the gap. So it's great to be here on the land of the Larrakia people, in a room filled with such strength, such representation from Aboriginal and Torres Strait Islander people from around the country, all with a common goal, to improve the health and well-being of our people, no matter where they live. Today, I'm here wearing two hats, as CEO of NACCHO and as co-chair of the End Rheumatic Heart Disease Coalition, an alliance of peaks, community and research organisations leading the work to end rheumatic heart disease in Australia. As most of you will know, the devastation that rheumatic heart disease is causing our people, you will know too well. Some of you will have lost family members and friends to RHD. Some of you yourselves will be living with the disease. And as Aboriginal health workers, a lot of you will be the ones on the front line of administering the monthly injections that prevent heart failure, stroke and death. End RHD's vision is simple, that no child born in Australia today dies of rheumatic heart disease. And in theory, it should be just that. Simple, because rheumatic heart disease has already been eliminated in Australia's non-Indigenous population. 94% of people who get rheumatic heart disease are our people, Aboriginal and Torres Strait Islander people. It's our children who are most at risk of developing rheumatic heart disease. Our kids as young as 5 years old, have open heart surgery. And without critical investment, the number of our people living with the disease will triple to over 15,000 over the next 11 years. This figure represents another 10,000 of our children developing a deadly disease that is preventable. We cannot let it happen. Today, my End RHD co-chair, Professor Jonathan Carapetis, is going to talk to you about the End Rheumatic Heart Disease Endgame Strategy, a plan for us to prevent these unnecessary deaths, to eliminate the disease by 2031. After him, we'll hear from Raychelle McKenzie and her mother, Noeletta. Raychelle was diagnosed with RHD at the age of 8. Half her life, she has been living with RHD, getting monthly injections to keep her heart strong. But first, I want to tell you all why ending rheumatic heart disease is so important to me. As Aboriginal and Torres Strait Islander health professionals, the range of issues that require our urgent attention is extensive. Doing everything means we can rarely choose to focus on a single disease. There is so much to be done. We can't afford to have favourite diseases. But rheumatic heart disease sticks out. It's the greatest cause of cardiovascular inequality for Aboriginal and Torres Strait Islander people in this country. We get it because of crowded houses, because a lot of our people don't always have access to hot water, to showers that work, to washing machines that aren't broken down. We get it because our clinics are overwhelmed with demand, and sometimes skin sores and sore throats go untreated. We get it because rheumatic fever gets missed, and sometimes it's too late for treatment. At NACCHO, we became a founding member, a partner to the End Rheumatic Heart Disease, not because this disease is simple to fix, but because it's hard. Because it spans from housing to clinics to open heart surgery and exemplifies the gaps in the health system and in the outcomes. We are focusing on this disease because the only possible solution is comprehensive, Indigenous-led, primary healthcare-based strategies of both prevention and treatment. Our people know what needs to happen to end rheumatic heart disease in this country. In fact, community-driven work is already underway across Australia. Our communities are rising, demanding action, demanding support to prevent the next generation experiencing this unnecessary suffering. But what we've been missing is a blueprint that ties it all together. A collaborative strategy involving community, government and research that outlines what needs to happen, who needs to do it and what it's going to cost. A plan that has been informed by Aboriginal and Torres Strait Islander people and communities, our perspectives and expertise, and aligns with community-controlled work and principles also of the Coalition of Peaks. And that's exactly what this rheumatic heart disease endgame strategy offers. If fully funded, and the Minister hasn't quite got his head around this yet, but he needs to, so I'm talking to his bureaucrats here, he really needs to understand that the money for the vaccination and the money for the research is, we also require the money for the endgame strategy. And the Minister really needs to get his head around that. So, if we're fully funded and implemented, not only will this strategy eliminate rheumatic heart disease, it will significantly help to close the gap in health outcomes, because by addressing the root causes of rheumatic heart disease, we will also eliminate other linked conditions like scabies, ear infections and kidney disease that unfairly blight our people. The Rheumatic Heart Disease Endgame Strategy is research with an impact, a solution to rheumatic heart disease that we can all be a part of, and I ask you all to please get behind it. I'd now like to hand over to Jonathan to talk about the key recommendations of the strategy. Thank you, Jonathan.
Thanks, Pat. Thank you, Pat. It's a pleasure to present, if you like, a taster to what's in the Endgame Strategy. As Pat said, this has been a 5-year piece of work to pull it together. It'll be formally released early next year, but we wanted this conference to be the first to hear the core recommendations. Firstly, let me just give you a very brief background. A lot of you know rheumatic heart disease, some of you may not. So just to clarify that this is a disease that begins as an infectious disease and becomes a chronic disease. So it begins with exposure to a bug that's called Strep A, that we all encounter as kids, and unfortunately it's encountered far too often in Aboriginal communities. It's the predominant cause of skin sores and also a major cause of sore throat. And in some people, that Strep A infection leads to an immune reaction that results in a disease called rheumatic fever, a nasty condition that causes things like swollen joints, high fevers, unusual movements known as chorea, and of course can damage the heart, causing carditis. As a young person, this is usually a disease of childhood, encounters further streptococcal infections, further skin sores, further strep throats, they can get rheumatic fever again and again. And each time that damage to the heart gets worse, that is rheumatic heart disease. It causes heart failure, shortness of breath, swelling. It can have complications such as stroke and infections. It's a very severe disease that can require people to have cardiac surgery, certainly medications, and unfortunately can be fatal. And that's the disease we're trying to tackle. Pat's already given you a bit of a background about the size of the problem. We've done a lot of quantification of the size of the problem of rheumatic heart disease in Australia, and very importantly, in a report that we released last year, what would be both the cost and the burden of doing nothing more, the cost of inaction against rheumatic heart disease. And that cost would be felt in the trauma and the suffering and indeed the deaths of many people around this country, almost all Aboriginal and Torres Strait Islander. And Pat's already talked about if we do nothing, there'll be another 10,000 cases on top of the existing cases. There'll be an extra 500 people dying unnecessarily between now and 2031, and that's unacceptable. There are many things that can be done to control rheumatic fever and rheumatic heart disease, and I've defined them on this slide in different levels. And what's critical is you understand that there are things that can be done right at the start to reduce the exposure to the strep. It's called Primordial Prevention, and we'll talk a bit about that, but that comes down to the social determinants. This is at its heart a disease of injustice and of the social determinants. There are things that can be done when someone is exposed to a strep, when someone gets a skin sore or a sore throat, and there's treatments that can be offered. Obviously, the Minister mentioned the work towards a vaccine. That is going to be critical. It's important. It's not going to happen in the next few years. The funding he announced is to get a vaccine into a first clinical trial within 5 years. We know that there's years after that until we actually get a vaccine that we are confident can work for rheumatic fever. So it's really critical that we do that work, but we must not let that divert us from the work that needs to happen on the ground right now. And then there's a number of other things there. So we know that we need to get better at diagnosing rheumatic fever. We're working on new treatments for rheumatic fever. That's all critical. Secondary prevention. What do you do for someone who's already got rheumatic fever or rheumatic heart disease to stop it getting worse, to stop them hopefully stop them progressing to rheumatic heart disease or their rheumatic heart disease becoming severe? The cornerstone of that is secondary prevention. It's the regular penicillin injections, those painful injections, and we're going to hear from someone who lives with that every month very soon. And we need to be able to do better at that, at delivering those penicillin injections, because they work. They do work to prevent rheumatic fever. But we need to also understand that there are things that can be done around better diagnosis, the early echocardiographic diagnosis of rheumatic heart disease, and then how to intervene earlier. And yes, we are working on better formulations of penicillin. All of these things are part of the puzzle. And then tertiary care. What do you do for someone who's already got established rheumatic heart disease to stop them dying from it, to improve their quality of life? medical care, surgical care. Particular focus needs to be happening on women with rheumatic heart disease and also on adolescents with rheumatic heart disease. What I can tell you is the Endgame Strategy recognises that in the past we've tended to pick one of these things. We've tended to look for the magic bullet, and there is no magic bullet. We've got to do it all, and that's what the Endgame Strategy is about. And so what we did a few years ago was, on the left of the slide, we pulled together the major research organisations working on rheumatic heart disease, pulled them together in the End Rheumatic Heart Disease Centre of Research Excellence. Our task over these last 5 years is to pull the evidence together, to map it against the policy recommendations, to look at the costing, and to develop the Endgame Strategy. A few years ago, though, we recognised that that's all fine, but if that's going to be not going to be just a document that sits on the shelf gathering dust, but is actually going to be implemented, there was another part to the puzzle, and that was the advocacy, the policy, and the translational outputs. And that's where how End RHD was born. Pat, I thank you and congratulate you for your leadership. The Aboriginal community-controlled health organisations have been at the front directing how End RHD works, pointing out that we need to focus on the root causes, pointing out that this cannot be done without action in communities, without the community-controlled primary healthcare sector taking the lead. And so the Endgame Strategy is a product of all this work. It's been an interesting exercise for someone who's at heart a researcher to recognise that science is only part of the puzzle. And so I'm going to just quickly take you through the 5 key areas that will form the Endgame Strategy, very briefly. So the first one is creating a national Aboriginal and Torres Strait Islander-led structure to drive the implementation. We need, and we've given it different names, it's a national technical agency, we'll figure out what it should be called, but it has to be led by Aboriginal and Torres Strait Islander people. It needs to be able to both advocate at all levels, particularly including governments and including outside of the health sector, because many of the solutions are outside the health sector. It needs to be able to provide technical support to communities for the sort of things they need to do on the ground. It needs to have the capacity to allocate funds, to make place-based grants to communities, to implement things that they know will work for them, to seize on the existing organisations, RHDAustralia, for example, that develop and maintain really wonderful education and training resources, and of course to monitor and review progress. The second one is really critical, and that's the fact that we have for far too long relied on top-down solutions. This needs to be empowering communities to take control, to implement the things that matter. And so there's a whole lot of things that need to happen at the community level. When the community puts its hand up and says, we want to get rid of this disease, how do we provide the support to allow them to do that, to make sure that the Strep A infections are managed, that people are aware, that we provide high-quality secondary prevention, that we allow them, when they recognise that there's a significant burden of disease, to mobilise echocardiographic screening and make sure that the kids who are identified are properly treated. And that this all needs to be done with an Aboriginal workforce that's local, that's properly supported, and obviously the Aboriginal community-controlled health organisations need to be in the lead for implementing this. And we know right now that there are many communities already trying different solutions. There are 11 communities that go under different names, but they're already working around the country to implement local solutions to control rheumatic heart disease. We need to support these, to continue them, and we need to expand the number, and we need to learn the lessons about how they do it and transfer those to other communities. The third element really gets down to, the third, fourth and fifth are about the sorts of things that need to be prioritised at that community level. And this is really critical, and this is precisely what the Aboriginal community-controlled sector has been telling us for years, and we've only recently started listening properly, and that is that there needs to be a focus above all on the social determinants, particularly environmental health and infrastructure. And so we need to tackle the environmental determinants, we need to support the appropriate housing infrastructure, and that includes housing maintenance. Things like housing for health need to be supported, investing in local environmental solutions, and indeed the sort of things that the environmental health practitioners are already practicing around washing of clothes, around daily hygiene, around daily hand washing, around getting rid of the rubbish. Those are the sorts of things that need to happen. We need to really embed this in the primary healthcare provision within the communities. So the social determinants, particularly environmental health, are to the forefront. We need to be focusing on comprehensive skin and throat programs for the high-risk communities. Skin infection and throat infection are the root causes of rheumatic fever, and we need to enable communities to control them. And there are a range of different strategies for doing that at the household level, at the primary healthcare level, at the community level, engaging the schools. There's a whole lot of strategies that could be implemented around this. And then finally, for those who already have existing rheumatic heart disease, we need to guarantee that they can get the best care. And that includes essentially focusing on their care coordination, pre-op and post-operative support. We have excellent cardiac surgery in this country, but it's the lead up to it and it's the follow-up that needs to be better supported. We need to fund positions within the primary healthcare services to coordinate care. We need probably regional coordinators in high burden areas for ensuring CQI, health promotion, developing transition models for adolescents, developing pathways for living with rheumatic heart disease during pregnancy, and coordinating peer support programs and events. So there are 5 critical elements to this strategy. We've got them very carefully mapped out. There'll be a lot of detail in the Endgame Strategy about how this looks, what it costs, and as Pat says, we are now working hopefully to take up the Minister on his invitation to be hard on him. We are going to be hard on him to make it clear that this is not just research funding, this is funding for work on the ground that needs to happen now. And we've done the modelling and we know that if we do this, that the impact is going to be dramatic. This is rheumatic heart disease prevalence by 2031. If we deal with the crowding issues, the environmental health issues, primary and secondary prevention, and this is the impact on mortality for rheumatic heart disease. And if you look at the bottom there, our aim is by 2031 that no child shall die of rheumatic heart disease. We can do it. The modelling is there to show us we can do it. We know that we can. If we get the resources, we've got the certainly motivation to do it. And so to that end, we now need to hear from some people who live with this day in and day out. There's a wonderful program that RHDAustralia has been supporting over the last years that really mobilises people living with the disease in communities to be champions for change. I highly recommend it to you. And we're delighted that today we've got Raychelle, who goes by Ray, and her mother, Noeletta McKenzie, here to tell their story. Can I ask you please to put your hands together to welcome them?
Hello everyone, my name is Raychelle McKenzie and I'm an Unbuttered Diama woman from my father's side, West Arnhem Land, and I'm a Luricha Yamachi woman from my mother's side, which spreads down from Alice Springs up through WA. And I have rheumatic heart disease, and I'm a champion for change. Yeah, do you want to say?
Oh. What do you want me to say? I'm just here to support Ray. I'm not probably going to say much at all, but I want to acknowledge there's a couple of people in the room. Old man Gunnaburra from Manningrida Clinic, Ray, Dr. Josh, Dr. Bose somewhere here, Margie. These people we've worked really close with through Ray's journey. Just want to acknowledge all the help and support you guys give us as well.
Yeah.
So you can talk.
Today I thought I'd share a bit of my journey and how far I've come with my RHD and the services that have helped me. So I started developing skin sores and a rash after I'd gone to the National Indigenous Music Awards. I'd been rolling down on the hill. When I was 8 years old, I was only little, and we just thought they were from the grass, you know. That it was nothing really severe, and it went away. And I was fine after that. We relocated back to my remote community, Manningrida. And 2 years later, I started experiencing skin sores around my mouth, sore joints. I couldn't walk, so I would paddle around on a skateboard, sitting down. It was pretty cruisy. And so then I started developing a little bit of a sore throat, and I went to the Manningrida Clinic twice for this, and they really couldn't give us anything about it. We had misdiagnosis, and this was about 8 years ago. Yeah, when I was only 8 years old. And so it was on and off, the symptoms. One day, like most days, I couldn't go to school, and then some days I'd be fine, running around, normal. So yeah, once my mum went to the clinic with my little sister, because she has kidney disease as well. And she was talking to one of the nurses about it and just talking about my symptoms and going over them. And the nurse was like, oh, where's this child? She needs to come to the clinic now. Like, we need to start action. And my mum was like, why? Like, there was no resources. There was no really talk or awareness about rheumatic heart disease in my community. And I was scared because when I heard heart disease, you know, I was a little girl, and I thought, oh, something's wrong with my heart, you know, maybe I'm gonna die, or, you know, it was really radical, and we didn't have much awareness or very limited support back then, coming 8 years. And yeah, so the next thing we knew, we were on a plane to Darwin, and they were taking my bloods like every day. I didn't know what was happening. I was really confused. And no one would really talk to me about it because I don't really think that they knew themselves.
Very limited training.
Yeah, there was very limited training and awareness around it.
I mean, it's a third world disease, you know, RHD. They've eradicated it in Africa. So why in our bloody communities are our kids dying of it? Meningrida's got the highest rate in the world of rheumatic heart disease kids. Like, what the hell's happening, you know?
My community only has 3,500 people in it, yet we have the highest standards of children getting rheumatic heart disease in the whole world.
The world, not Australia, the world.
Yeah. So, yeah, we were on a plane to Darwin, and for 8 years I've been getting injections, and I've seen the journey of RHD and seeing family and like kids that I've grown up with, you know, going from community, and you think they'd just be leaving, go to the show or come into town. They come back a couple months later and they have that big scar down their chest, you know. These might just be statistics to the services that are looking at them, but to us this is family, and this is kids, and they're affected, and you know, it makes me emotional because I was affected, but I never had surgery, so I don't know the experience they went through, you know, talking about countrymen family that don't have limited English and going to these big cities, dealing with all these doctors and foreign people that they don't really know how to communicate with, you know. They speak limited English. They're just worried about their child and want to get the best help out there.
And I think on that note, Meningrida's leading the way. The whole community is pulled together.
Yeah.
There's some great things happening in Menangrida, like the whole community. Dr. Bo, Dr. Josh, Malabam, they're working as a community.
Implemented a community whole-based strategy where there's resources being made within the schools that, because there's 13 languages in Menangrida, it's so diverse, and you know, many people speak many languages, but yeah. So they've developed resources in many languages through the schools, and hygiene packs and everything, and getting that education, healthy eating from the shops and through the schools, the clinic, also through the youth service. So they're all working together and communicating to try to eradicate this disease. Yeah. Well, I've since relocated to Darwin, and I live across the harbour at Mandorah because my sister has kidney disease and we had to relocate to be closer to the hospital. So now, yeah, we live in the city, in more urban areas, and now I'm a part of the Champions for Change, and that's with RHD and funded through Menzies. And what we do is we create resources and we meet up and we talk about the main issues around RHD, and it's really just a community-based approach to how we can help end RHD, really.
And we do this, we come and tell our story at conferences.
Yeah.
This is the first time in a big room, it's scary. Yeah. Is that, okay, thanks guys.
Yeah, thank you for hearing my story. Sorry, I actually forgot. I'd like to acknowledge the traditional owners of the land we're standing on and all traditional Aboriginal people in the crowd today.
What a remarkable young woman, and Noeletta, you must be very proud. So can I implore you, please, to recognise that End RHD is not a club, it's not an exclusive club, it's a movement, and we want you all to be part of it. You will see on your tables a little card that gives you a bit of a background. It also points you to the website. And we would invite you as your organisations to come and sign the charter, but also individuals. Because if we're going to get this Endgame Strategy implemented, and if we're going to work on it over the decade it's going to take, then this has to be something that we all do. So please join us. I really would like to once again thank my co-presenters for that wonderful presentation, and thank you for your time.